Alrighty, and so I'm going to go ahead and share my screen just to welcome everybody. So welcome today to our Indiana State Suicide Prevention Plan Crisis Services virtual listening group. So our agenda for today, we're going to talk through our introductions really quickly. We're going to talk about the session's purpose. Then we're going to go through the brief crisis continuum overview. And then we're going to spend the majority of the time getting your feedback, really listening to you all and, helping us move this plan forward. So going first, my name is Lana Leip, and I'm the Assistant Director of Suicide Prevention and Crisis Response here with DMHA. And I'm going to stop sharing so we can see our other folks in the group. All right, Alana, go ahead.
Yeah, so I'm Alana Rosenbaum. I am the Assistant Director of our Behavioral Health Services at Adult and Child. So I oversee quite a few different teams, but two of them being our Mobile Crisis and Crisis Center team. And I will be co-facilitating with Lana today. So you get a Alana and Lana, not confusing at all.
Not at all. All right, and then Laura.
I'm Laura Barrett. I'm Vice President of Behavioral Health for Adult and Child. I oversee multiple teams, but our crisis team as well. So thank you for joining.
All right, and then last but certainly not least, Elizabeth.
Hi, I'm Elizabeth Yeager, and I work at Cummins Behavioral Health. I'm working on, I have poor quality internet right now. I'm so sorry. My computer keeps acting really weird, but I'm just going to be monitoring the chat today and taking note of all your questions. So.
All right. Well, thanks for those introductions, everyone. And so again, this listening purpose, the listening session purpose for today, at the state, we are updating our Indiana State Suicide Prevention.
I would just do the AC.
Okay. And if
everybody can just please make sure you mute so we don't have any disruptions. Thank you so much. So again, at the state of Indiana, we are charged with developing the Indiana State Suicide Prevention Plan. And part of that really is getting, the rich feedback that you all in the field and then you all with lived and living experience do have to provide to us. So the information that we received from you all today in the listening session really is going to help us inform that state suicide prevention plan. So with that, I'm going to go ahead and kick it on over to Alana, who's going to give us a very, very brief crisis continuum overview.
Yeah, so like Lana said, we want today to be about hearing from you guys of what's gone well, what are some opportunities of growth, but to make sure that we're all on the same page, speaking the same language, we're going to talk through the crisis continuum real quick. So there could be folks on the call that have lots of questions about this, and we welcome those questions to be in the chat, but we're not going to spend a ton of time going through what these should or shouldn't be, those types of things, because we really want to hear from you guys about these process, but it's important that we get an understanding of what the continuum is. So best practice is a three-prong approach, there's 3 pillars. So someone to contact, so that is crisis lines, 988, those types of things. Someone to respond to our mobile crisis teams that are going out across the state of Indiana, and then somewhere to go. So that is looking at our crisis receiving and stabilization units, our CRSS, that somebody can go to. So really thinking about the model of individuals in crisis should get to choose how they get that crisis support. And so having all 3 of these pieces. So you're going to hear these terms today when we are talking through. So when we talk about someone to call, someone to respond, somewhere to go, those are the pieces that we're talking about in the pillar. Okay. So to kick us off, we would like to hear from you guys of what is your understanding of the crisis continuum and all of the pillars.
And just as a reminder, today's today's session is going to be recorded. So please just make sure that we're not using any personally identifying information, that we're not going into specific details, because this information will be shared out to the broader public. Also, if you all can make sure that you keep your microphones muted, just so that way folks who are talking, we can hear them. And then again, if you all don't mind using the chat, if you don't feel comfortable speaking, out loud, we will definitely be moderating that as well. And do we have our first question that we would like to pose to the group handy? And then, yes, I do see in the chat that we will also receive the slide presentation. Yes, that will also be sent out to you folks as well afterwards.
Yeah, so I think that first question that we'd like to hear from you guys is, what is your understanding of the crisis continuum and all of the different pillars?
And so when it comes to that question that Alana just posed, what is our understanding of the crisis continuum and all those different pillars? That can be from your experience as a professional, as a person with lived or living experience, or a loved one with
so
lived
you
or
didn't
living
need time off, and
experience.
you said that you might be able to.
I think it's something that we use like in order for people to feel like they know what they're doing in a moment. When these crises come up, I think it's easy to be like, well, I'll just call 911, I'll have the police come, but like police aren't always like trauma informed about things. So having this crisis continuum, like of someone specifically to contact who's trained in these things, someone who's actually going to come and respond, that like people feel like, okay, someone's coming, I can like kind of hold off for like the 10 minutes or whatever it takes for someone to get here. And then having somewhere specific like to go in those instances, like, I don't know, that's kind of my understanding of what it is. So yeah.
Yeah, thank you for sharing.
From my perspective, it's more like the guardrails for us. Those stop safes, those, just kind of gives us those touch points, that they know they have someone to call, and making sure that we have an open pathway for them to call in each county or each area, someone to respond, making sure we have designated and trained staff to be able to respond to the population that need, and somewhere, I think it's somewhere to be. Is that it now? I know the language
Yep,
changed a
somewhere
little
to
bit.
go. Yeah.
There's somewhere to go. I know it changed from that safe place to be. And so just making sure that when we're done with our interaction, that young person is safe in the least restrictive setting as possible.
And how do you operationalize that, Derek, especially when it comes to young folks?
Well, in Indiana, it's really, really tricky. First of all, we got to get that parental consent. Um, just because there's no code around being able to treat young people under 18 without parental consent. So that's the biggest thing there as far as operational wise, making sure we get that parental consent, and just kind of getting out there. Well, it depends on how you're asking this question, because I can kind of dance around it. So I think what you're asking is that overarching thing, and so that's just having that crisis center is what we have. It's kind of they answer all of our calls from the adult and the youth, and then they send them over to us, which will be that someone to respond. And then our team will try to get out there, will contacts them, offer to mobilize to them. If they want mobilization, our goal is to be there within an hour. If they don't want us to mobilize, our goal is to meet their needs over the phone and provide the resources that they need right then and there. And same thing, if we mobilize to them, just identifying the most appropriate setting for them to get through the night, to keep the young person and the family safe. and prioritizing the least restrictive, trying to keep them in the home. If the home is not available, we looking for those natural supports, the other parent, grandparents, the nosy neighbor. Then we utilize the community, which would be with emergency shelters. And then what I've noticed since we've been doing this work, and that's where the gaps begin, because there's not many community pieces there. And then in our work is a diversion program, so we want to divert them from having to use the ER, emergency hospitalization, and the ER. Well, they already said ER, and law enforcement. So the goal would be to try to put things in place so they don't have to use those, but those are needed. We make sure we get the appropriate people involved. Is that what you were asking?
Yeah. And really quick, you had also mentioned consent as well as some gaps, especially when it comes to youth. What are the gaps that you have seen in your work related to that or related to getting folks in the least restrictive space possible?
The biggest gap is when we're having that family discord. The young person might have a history of aggression, so they might not fit into they might not fit the criteria for the emergency shelter. But at the same time, they don't reach the level of need to be removed from the home as far as acute hospitalization and things like that. And so that's kind of where the gap I see there. Those with disabilities, such as intellectual disabilities, being able to find something for them when they are in crisis. Let's see, what else is there? Yeah, it's just, I think those are the biggest ones. But you put me on the spot that I would have had like to had a list for you, because there's more there. Like last night when we talked about that consent, we mobilized to a young person. Well, let me rewind. Dispatch called the crisis center, and the adult team went out. And when they got there, they realized it was a 15-year-old. And the 15-year-old said that the parents were on meth. They didn't want to go home, and there's really no. They called us out, but there's really not much we can do because we don't have that parental consent. And so my team was kind of stuck at that point. That we had a couple options as I had a chance to sit back and process it, but there was nothing that was obvious right there in the moment when everything was happening, if that makes sense. And so those are the type of things that we're seeing.
Thank you for
So
sharing.
this is Jim Ballard with City of Goshen, Elkhart County CIT. And when it comes to law enforcement, the statute does not differentiate between an adolescent or an adult, whether it's under 18 or not. So if we have a child who falls within the EDO statute, we're transporting that individual for the most part to the ER to be evaluated, and we're completing the officer's attestation. We don't need that parental consent for that. We also have changed how we do that. In the past, we used to allow the juveniles to be transported by the parent and let the parents work with the hospital without doing the attestation. But like someone said before, we don't know where that trauma is coming from. That trauma may have been coming from the parent. So we're not going to allow that parent to transport them to the hospital. And I think an option that you're looking at, from the law enforcement perspective, is a Chin's case. If both parents are falling under, they're addicted to meth, and that child's not in a stable environment, then we'd probably do it Chin's.
Thanks for that feedback. And I do see that Mick has his hand raised.
Yeah, thanks, Lana. one of the things that we're getting is because our mobile team is just answers any calls, obviously, and we have the CRSS with us as well. We get during the days a heads up from a case manager from the schools that they've had a child at a school all from elementary all the way up to the high school that somebody's en route with a parent or with the case manager. When we get that, we call Amy, who was speaking earlier, and she's got a fit team. So she finds somebody that's available and tries to intercept as they come to our unit. And so that's kind of how we're operationalizing that. We're getting 12 to 13% of all of our calls are under 18, and many of them are under 12. So we're not being asked to track that stat, by the way. It's 12 to 18, but we're getting quite a few 7, 8-year-olds. Couple of the things that we see is the gaps is transportation. If they do need and fit that criteria for inpatient, the gaps in transporting them clear down to Bloomington or Fort Wayne or up in Mishawaka. My team can't take them there. The parents many times can't or say they can't. So we really run into a big gap in that situation because we can't send that kid with somebody else. The only place that could really guarantee transportation is one of the places we're trying not to use, and that's the emergency room. Send a kid to the emergency room, they spend 18 hours there getting placement, and then an ambulance takes them. And we've really got to find a way to be able to get especially the youth someplace when those parents can't take that for whatever reason it is. A non-judgmental piece. It's just they can't. So that really becomes difficult because the placements are nowhere near where we're at. And we've got great relationships with all y'all in the state to do that, but we just can't get them there a lot of times.
Yeah, I appreciate that feedback, Mick. I know that some of our teams have been asked the question of like when we're asking for an ambulance of why aren't we using like a private ambulance service? But right, most of our private ambulance services, one, there aren't very many, but two, you have to schedule those out, right? So in that crisis moment, that's not an option. So yeah, I see and hear that daily. Yeah. Thank you for sharing.
Another issue with transportation is some of the private ambulance services will not transport unless there's an EDO in place, unless an officer's with them. So that's tying up officers traveling to, we're in Goshen. Sometimes we have to go to Greenfield or Harsha, which is a 3-4 hour trip one way. And so we're working through those transportation issues, but transportation is definitely an issue.
Is it Brianne? I see your hands raised.
Yeah, Brian, very close.
Brian. Yeah.
Yeah, so I, from a professional perspective, I get to be a crisis therapist with Cummins Behavioral Health here in Avon. And I kind of wanted to double click on the idea of the continuum from a parent's perspective, because what I realized over the last year and a half or so of working as a crisis therapist is that often parents don't understand that there is a continuum. And so I think something that gets missed really often is realizing that there's a continuum even within their own home and within a family unit. And so oftentimes even bringing up something like, hey, is an aunt or an uncle around? Do you have a family friend that's trusted? Like sometimes the idea of respite or going somewhere, we jump immediately to the idea of hospitalization or things like that. Whereas we have an entire continuum within the home that isn't often thought of. So I just wanted to bring that to light as something that I often experience and something that maybe we can all kind of think on when we're providing services.
Yeah. I think with that, can I ask, have there been things that you found successful when working with families to to be able to provide some education of here's what this continuum means and looks like? Have you found success in being able to do that we could build off of?
It kind of depends on the perspective that the family's coming from. So very rarely, but very enjoyably, I get to experience parents who are being preventative. Hey, I know I have a kiddo with these specific issues going on. Right now, we're not in crisis, but what should I do if and when? So that is like one of the best moments. I had one this week and it's fresh in my mind. And so we were really able to kind of jump into that and explain from a very calm point of view. What we often see is an escalated parent or an escalated guardian themselves dealing with an escalated kiddo. And so if we can kind of bring parent to baseline, have them model the behaviors that we're hoping kiddo will also model, then once the kind of like the fire is out, that is really a good time for the teaching too. Hey, what was leading up that now with fresh eyes you can notice? Oh, they did have a really bad day at school. Oh, they skipped breakfast this morning. Like, they can kind of start to become a detective themselves. And when they think of what led up to it, then I feel like they feel more confident of like, what can I do after and like when the crisis is happening. So I always try to focus really hard on encouraging and empowering the parent and not just giving them ideas, but saying, you know, your kiddo better than I will ever have any chance to. So in those moments, what does help that maybe we haven't just thought of right now because our brain is kind of, overstimulated.
Yeah, thanks for sharing.
Mm-hmm.
Chad, I see you have your hand raised.
Yeah, a couple things. I agree with Mick. We're seeing more and more kids that are under that age of 12, which really gives us an issue if we do have to work on placement, because there's only a few places in the state that will take that young child. And then when you get to that, it also depends on the age of their youngest person in that system. So there's some places that they'll take 8-year-olds, but if they only have 12-year-olds, they're not going to take an 8-year-old because that's too young for the group. Okay, so it becomes a new barrier that way. And then I think that when we go out and see young people, for instance, we make sure that that individual knows we're there to see them. Okay. And give that kid some power, because then we can de-escalate. Last night was a great example. We got a call from law enforcement that there's a 15-year-old. He had supposedly lashed out to his mom and got upset after she had taken him to basketball practice and bought him pizza and did all these great things for him. And then he got mad when they got home. Well, come to find out, once were able to talk to him, mom was hanging out with a guy that has not been good to him. And so that was his way of basically keeping that guy away from that house. And it worked, essentially. I mean, he showed up while police were there and police sent him home. But once we got to that why and figured out what was going on there, we were able to de-escalate everything, get them separated. They've stayed in the home. Then we got them an emergency appointment with a provider the very next day. So that's been a key to what we've been able to do, is get people crisis therapy appointments the next day. We have a couple of different providers that are doing that. So that's, so when you can tell the parent that, okay, maybe here at 10 o'clock at night, there's not much we can do. And unfortunately, your kid doesn't fit criteria to go inpatient. You could take them to the hospital. We told her you could take them to the hospital, but you're going to sit there for 6 hours. The outcome's probably going to be the same. You're going to come home because he's calm and there's nothing going on at this point. So she chose not to do that, of course. But then by saying, hey, we'll get you an appointment set up first thing in the morning, we were able to call a provider, get that done. And so now that took that off because there was a plan to do something, so that's what we really worked on. And then I heard mention of intellectual disabilities. So we work with a lot with intellectual disabilities. I have a team that is very highly trained in that. And so very first question we ask when we walk into somebody with intellectual disability, is there a behavior plan? First question. Because when we ask that question, then we can find out what kind of supports they do have, and then we can work and use some of the same skills that the behavior consultant has set for that individual. So we're not coming at this completely blind. I think that, especially in a group home, I very seldom believe that an individual needs to go to an inpatient setting, because as long as you can de-escalate everything, then you get them separated, get that individual to bed or whatever that might be, and it's done. The problem we're running into is we have a couple of group homes that we've been going to frequently that they're not training their staff in de-escalation. So that's also a barrier. Sorry, there was a lot there.
No, don't have to apologize. I think these are all helpful things to be able to talk through when we talk about gaps. One of the things that I have heard in the last couple of people that I've shared is this idea of maybe what I'm curious of what information do we feel like about the crisis continuum has made it all the way into the community, right? So which pieces of this continuum or the process, right? I always talk about that the system is hard to navigate, and that's one of the reasons of why we want to make this better. So which parts of the system have we felt like from a marketing or educational perspective have made it to the community, and which are missing pieces that we really feel like we haven't quite hit enough for, right? Those youth, those families, those adults that are in a crisis moment that they don't even know, right? You don't know what you don't know.
I can jump in on that.
Yeah.
So I would say almost everything hasn't reached the community. As we do these outreaches and ask people about 988, about mobile crisis teams, about crisis stabilization units, 95% of the people have no clue what we're talking about, even professionals. As we do these outreach events with other professionals, we were just at a prenatal fair, women's health, and there's a lot of crisis services, things like that, that only half of them knew what 988 were. Very few knew about mobile crisis teams, and zero knew about crisis stabilization units. So I think it's something we got to look internally about educating the masses. And until we do that, we're going to all fight the same issues, because we all know it. But if the public doesn't know it, they're not going to utilize the services. So marketing, education, we need to be more on top of all that. We need to be able to do that. Because it's only hurting our communities at this point, and you can see it time and time and time again.
Thank you for sharing. Tracy?
I think some of the struggles that we have are like the EMTALA laws. So when somebody shows up at the emergency room, they can't even redirect them and say, hey, the crisis center next door would probably get you in faster. They're not allowed to say that. It would be nice if people showed up that they could give them a resource right there that would be somebody that could start working with them right away, or call us over and we could get started earlier maybe. But because they have some legal reasons, they can't do that. So that would be a barrier that maybe we could address in some way that would help people get redirected and get help more quickly. And I think there's a misconception sometimes too, that if you go to crisis services, the whole point is just the gateway to admission. And so trying to change that perception in the community that, yes, we go into crisis services and the only reason is to get you inpatient. So we've actually had providers refer to crisis services, and the people come in the door saying, my provider said I needed to be an inpatient services. Not that I needed crisis services, but that I needed inpatient. And so we start right away trying to re-educate. And then we've had some people leave mad, walk over to the emergency room because then they think they're going to admit them over there. And then we go over to do the consult in the emergency room. It's the same people coming to provide the service, just in a different location. And so just really getting that information out to the community so that the community knows we're there. And it's working. I mean, we doubled our numbers probably from January to March, but it's a slow process and getting that information out there and getting it to all the right people.
Thank you for sharing. Chad, I see you have your hand raised again.
Yeah. So what I've noticed is, we went from 3 counties to 4 counties to 12 counties. And so what I've noticed in that process is that it takes almost a year to get a county completely on board of what's going on and who to call and everything like that. So the first 3 counties call us all the time. 4th county calls us half the time. The new counties call us here and there. We've seen our numbers go up, but it takes that community outreach to really get them to understand. What I'm finding is a lot of times, they may know what a crisis team is, but if you do run across somebody who knows what a crisis team is, they're thinking it's just for those that have suicidal ideation, or just for those that are substance abuse, because there has been so much talk about peers and things like that. Then when it comes to the intellectual disabilities and it comes to the kids with behaviors, people don't know that the crisis teams will come out and help with that, and so I think that's another big hole that we've been fighting. And like I said, they know and those people that are undiagnosed dementia, I mean, we've been able to help with those along the way, and law enforcement doesn't, or anybody doesn't know, hey, let's call the crisis team and see if they can guide us through this process.
Thank you for that. I know I'm co-facilitating today, but overseeing some of our teams, one of the things that we have had to do over the last couple of years is do some of our own internal re-education of defining what a crisis is. So as you said, Chad, like when we think about crisis, the thought is suicidal, right? Or substance use, but really shifting the perspective. And I think I'd be curious of what others feel like across the community too, is a crisis is defined by that person. So it might not fit those risk boxes that we talked about, but what would it be like to be able to support individual in crisis that is something else that doesn't fit into those categories of risk? And how could we support somebody so that they don't get to a place of risk too? So I think it is expanding when we hear crisis. What does the word crisis mean in that definition? Any other thoughts about kind of knowledge or education about the continuum and the different services that are offered before we shift gears a little bit?
Alana, the only thing that I would say is what I put in the chat, is every county, I really believe in this, needs to apply for a SIM workshop, because that will identify everything. The things that are going well and the things that may need to be worked on. And until a county does that, this question is almost moot. So we need to identify every county's crisis continuum so we can kind of figure out, where the gaps are.
And Lance, for those of you, would you mind explaining what SIM mapping is for those who may not be aware of what that is, or why that's important?
If there's anyone else on the call, I see Barbara is on there. I don't know if she wants to hop in. Yeah.
I can. Thanks, Lance. So SIM stands for the Sequential Intercept Model Mapping, and it looks at the continuum of care as intercepts within how someone interacts with the justice system. There's also maps for where you don't necessarily need to go into the justice system, but at each intercept, how can you get someone when it's more appropriate for them to be in care? How can you kind of guide them in that way? So it goes from everything from intercept 0, where it's that before there's a crisis, Um, intercept one being when, someone may call 911 or 988, where there may be police involvement, all the way through reentry, and looking at each of those intercepts within that community and bringing all of those community stakeholders together and literally mapping that out, and what do they have at each intercept that's available in that community. It brings everybody into the room. They, of course, get to know each other, but then they all also find out what do they have available and what don't they have available. So it identifies those gaps in the community. And then as a community, they, after they've identified the gaps as well, then they can work toward filling those gaps. And they do, in fact, put together a plan to identify, or rather to correct those gaps. And so as we start to build that out and have them for different communities, we're hoping to get them online and identify those gaps more broadly. And so maybe we can even see wider gaps within the state as well. And this is for adults, but there's also one that we want to work toward that is for youth as well. That again identifies all of those points to support them into care.
Thank you so much for that. And Barbara, can you remind us how long, I can't remember off the top of my head, how long is that sim mapping good for? Because, right, there is some reevaluation that happens too.
Yeah, you're exactly right. So the actual mapping workshop itself takes about, leading up to the workshop, it's a few months, 2 days for the actual workshop itself. And then that's good for about 2 to 3 years. And then you need to come back to the table and update it, because hopefully you've filled in some of those gaps.
Yeah.
I'm actually involved in 3 counties in Sims mapping. Fourth one is actually going on today, and they're all at different levels. So one started 2 years ago, one started a year ago, so on and so forth. And as crisis teams being at intercept 0, having law enforcement in that room and understanding, hey, we can call these guys now and hopefully avoid even getting into that system has been a great way to divert, because they start knowing who to call and when to call and things like that. So yeah, we've seen a huge change, and we're starting to work on it in Allen County as well. Also, there is crisis intervention. I'm trying to remember. It's CIM, crisis intervention mapping, which is veteran based, which is starting in Allen County. They're actually presenting a check to fund that today. So that's specific to veterans. So and that's going to be coming to Allen County and the surrounding areas here. We've already had our first meeting. We'll be having our second soon.
Thank you. Megan?
Hi there. This is the first I'm hearing. I'm relatively new in this position. I'm still learning, but this is the first time I'm hearing about the SIM stuff, and I feel like I need to know more information on that. Help, how do I connect with that or learn more about that?
Megan, I will put our email address in here, and please feel free to follow up. Our justice director would be more than happy to talk more about it. She's actually currently at one right now.
Awesome, thank you.
So shifting gears just a little bit, and we can always come back to a previous topic. So we are pretty flexible co-facilitators. So crisis world we have to be. But we are curious to hear from some folks that have had interactions with each part of the continuum. So being able to share what went well during that interaction, whether it was a crisis line, whether it was a mobile team or a CRSS, what went well, and any opportunities for growth that could have gone better. Would love to hear from someone's experience.
Well, I've been involved in the whole continuum. So we've worked with you know the from law enforcement to working in the jail. We've been called into the to jail to help with maybe a placement out of the jail. We've also been in through Sims mapping. Okay, we helped the jail identify that they needed a jail navigator in one of the counties. So we're working closely with the jail navigator. We actually got a call today because they've asked us to help transport individuals who need are leaving the jail and have figured out what that next step is and don't have a ride. So we're helping with that as well. We have taking people to the crisis stabilization units has been a really good part of this continuum to be able to get them safe for the night and figure it out from there. And then one thing that's real, like I said earlier, really worked for us is working with different partners to be able to get somebody a crisis therapy appointment within 24 hours has been really huge in this process. To be, because that really helps with the diversion. I can't speak about that enough, how much that helps, because especially with kids, because mom and dad are saying, well, they need to go inpatient, but if they have an appointment tomorrow, can you keep them safe for tonight so we can get them this appointment? Sometimes we get the appointment the same day. That has really been huge in diversion.
Perfect. Vanessa?
Yeah, sorry. Hi, Chad. I'm not familiar with you. This is Vanessa with Aspire. I'm over our crisis services and access. And Chad, you've been sharing a lot. I just don't know what your perspective is within the crisis continuum. There was nothing next to the side of your name, so I just was curious.
Yeah, so I actually am the supervisor in the Enact Mobile Crisis Team. Usually Brian Gill's on here. I'm usually out doing lots of community meetings to build this up. So a lot of times I'm not on these meetings due to that. So I'm up here in Allen County area.
Gotcha. Thanks so much for the discussion we've had so far. We really do appreciate that. And we'd also like to hear from some folks who maybe haven't had a chance to share yet. We've gotten a lot of really, really great insight, from those who have shared. But we want to have a variety of perspectives. So anybody else want to give some feedback on how you all have interacted with 988, mobile crisis, CRSS, maybe what's gone well, maybe some areas for opportunity. We'd really like to get some information here to make sure we are informing that as much as possible.
Yeah, Tammy.
Yeah, hi. Kind of reiterating what was just shared. Our team works a lot with the jail. We get a lot of referrals from our jail program. We don't have an IRACS program in our jail, but we do have a resource navigator and peers inside the jail. So when somebody's getting released, we receive referrals there and help people with transportation, housing, documentation, all of those big barriers that they come across when they get out. And then we utilize our local stabilization unit. We're kind of uniquely right halfway in between. We're in Kosciuszko County. We're halfway between Fort Wayne and South Bend. Halfway in between a lot of different places. We're kind of rural and out in the middle of nowhere, but we do have a lot of access to stabilization units. We utilize Oaklawn and Bowen Health both a lot. That's been, I mean, I just can't even begin to tell you how amazing that has been, because, you know, I know everybody's shared here today, time after time, you have people and you have no place, you know, to take them other than maybe ER or something like that. And a lot of times they don't know how to treat or deal with, you know, people struggling with substance use and mental illness. So the stabilization units have been a huge, they've made a huge impact on the work that we do. So that's probably the biggest thing. We have a couple of our peer coaches on staff that did complete the crisis peer training. So they are crisis peer certified, which is a fairly new certification that's out there. So we're excited about that. But yeah, I think kudos to the stabilization units. We refer 988 a lot. That's another really great resource. But yeah, that's kind of what we've been doing.
Thanks for sharing. Christina?
Hi, good afternoon. My name is Christina DeWitt. I'm a licensed clinical social worker and the clinical manager for our Connection Center with Hancock Health, which includes a justice navigation program, our peer recovery specialist, and our mobile response team for the county. I just wanted to share that through our work, we actually did a SIMS mapping years ago in which we had a justice collaboration. And so we have a phenomenal collaboration with our own local county between our sheriff's department. We have justice navigators that are within the jail. And then in my office, we have justice navigators that support as individuals are transitioning out. Our mobile response team works extremely closely with our law enforcement, fire, EMS, community stakeholders. So individuals actually call our mobile response team directly. We have a cell phone and a direct line in which they communicate, and our mobile response team is then dispatched. So with our continuum, I think it's fantastic. I will say some areas, I just wanted to note gaps. We do not have great outpatient care, so medication management and therapy for those that have serious mental illness. And then for stabilization, we are transporting individuals out to either Valley or Community North because we do not have anything immediate there in our local county. But even once someone, I would say one of our largest gaps is when someone is stabilized, transitioning back into Hancock County, there is an extreme lack of services for serious mental illness support. I mean, like truly, if any at all. So we have many individuals that are suffering and do not have the care that they need or not receiving the accurate care. I also did just want to note that one of the largest parts of our continuum as well, which I know is not noted here, is our system of care. We have a phenomenal system of care within Hancock County. And if it was not for our system of care, I'm not quite sure the collaboration that we have would be what we have today. So I just wanted to share all of that over in Hancock County.
Thank you. And I appreciate you sharing what's going well, but then also the gaps, because I think, right, we learn from other counties of what's going well in certain counties. Not all of those things are going to apply across all the counties in the state of Indiana, right? It's not appropriate. But there's lots of things that could apply. But then also, I think it is important that we talk about the hard things, right? There are opportunities for growth. Things are not going well or smoothly all the time. That's just the reality of building the plane as we're flying it. And so this really is a space of, we want to hear what those things are and any ideas that people have already of how to make sure that those are supported. Because those are the things that we really want to make sure to take back. So I just want to encourage people. Sometimes we're afraid to say what's going not great, but this really is a space to be able to share that.
Absolutely. And I just want to note that with our county, it may be unique to others, but possibly not. I know there's a transition with the CMHCs, but we have been, I would say, almost without a CMHC type service. So we have individuals with serious mental illness that have not received services or cannot. And so then we're trying to navigate, how do we have support outside of our county, which is not ideal for most of our individuals, right? They need care in the immediate, in which we do not have. So it's extremely unfortunate it, but thank you for encouraging that.
Curious, what do handoffs look like? So typically in a shift change or a handoff from one team to the next, these are natural spots that things can look messy. Brian, I see your hand, so I will get to you next. But I'm curious of what is it like when 988 gets a call and then transitions it to a mobile response transitioning to a crisis center response, knowing, again, anytime in transition to human the human reaction is those can be messy. So I'm curious if there are opportunities of growth in those types of areas. Brian, I saw you had your hand raised. It's okay if your comment or answer was not to that question. I want to give you a space to share.
It kind of crosses over anyways. I was actually thinking about what Christina was saying and thinking, sorry, I'm not on camera. For some reason, my Teams and my camera just doesn't get along sometimes. We have almost the exact opposite issue, is that we have a literal plethora of resources and connections that we can link people with. Even just in the last couple of days, we've gotten people through the continuum of traditional outpatient to residential substance. In fact, the mobile team right now is out responding to somebody who has a substance use issue. And of course, the excuse/reason of being the primary caregiver. And so kind of linking them with all those pieces to help that person to be a better family member to those that they're taking care of. But anyways, we've got all these wonderful connections that we can make, and yet the utilization of us is what is really lacking. We do have some really good relationships. One police department actually uses us quite often. The vast majority of police departments in our area, fire departments, ambulance providers, quite honestly just won't even recognize, won't acknowledge it. Hospitals as well, not so much. We're working on that, and I'm hoping for some progress there. It's kind of speaking to that handoff piece. It's 988 and that anonymity that a caller receives. I think somebody early on said that there's kind of an unfortunate accident involved with EMTALA. And I think that the 988 system, it kind of reflects that as well. You say utilization of us. I mean the mobile crisis team as well as the crisis or the CRSS. When 988 gets a call, unless that person says, yes, I want this assistance, that person remains completely anonymous. That said, there doesn't seem to be a really easy way to do a warm handoff through the phone system from the someone to call and the someone to respond and a place to go. And so oftentimes there's that very risky losing a connection and hoping that we can get that person back on the line. That we've had mixed results there. We actually had an issue just yesterday as far as kind of with attempting to get clarity and assistance with transportation for an individual who, for all intent purpose, was experiencing a significant crisis as newly defined by the state, was, for all intent purposes, gravely disabled, but was as pleasant as anybody I've ever met who was delusional and likely experiencing psychosis. And because of that, the first responders were like, nope, they seem fine. We're not going to take them. This is somebody that's not been able to provide meals without neighbors' assistance. This is somebody who is had their gas shut off, their electric shut off. They're about to lose housing, but no, they're totally fine. They don't need any assistance. Coming back to your handoff piece, we actually have been utilizing Teams quite a bit as to assist with the handoff between our mobile team, between the our primary crisis unit and an extension of that unit that we have. This allows us, no matter where we are and what we're doing, it allows us that direct connection. When that happens, before somebody transitions one way or the other, the entire team has some sort of an idea about what's going on with them. And what that really allows for a pretty smooth handoff when we do that. Hey Joe, this is our team. They're going to take over from here and help you get the things you need. With the police, we actually adopted a form that we borrowed from Indianapolis, that if a first responder is doing a drop off, primarily it's just been police officers. It's not required. We won't require it. We do require them to give us some information, but they fill out this one-page form. It gives some very basics. Not only what's going on with the person, how they come across it, and who are they as the person dropping off in case we need more information. They drop that form off and go about their way. We've actually been able, I don't think that an officer has been here with a drop off, those that have utilized us for more than 10 minutes at this point yet. That was a lot. Sorry to take up so much time.
No, you're okay. I have a couple follow-up questions, if you don't mind. So one, at the beginning, you talked about some providers, groups of individuals not utilizing you guys. I'm curious, we've talked about a gap being that people just don't know the information to utilize. Is that what you're anticipating? Is that what you believe is happening? Or, and this could be for anybody, are there other reasons why groups of people are not utilizing these types of teams?
I initially thought it had to do with the lack of information and I have had more experiences than I can count where I spoke with a chief or a commander or somebody of that nature, communicated with them verbally, as well as then sent them the link to the General Assembly for them to go read the code themselves and to see that these things have changed and explain to them what was going on. And I will paraphrase, the response was, okay, that's nice, but we're going to continue with what we've been doing. We still have departments that are looking for the EDO physician statement and a judicial order to transport somebody, and that hasn't been in effect since July of 23.
Okay. One of the other questions you talked about teams. I assume that that's an internal, right, from your internal team to internal team. Have there
Yes.
been any systems that have been successful, or maybe an area of growth when we talk about from one team that works out of one organization to come to another team of another organization? How do we communicate well, or areas of growth for those types of scenarios?
So that hasn't been really well defined. It is kind of what it is, very much grassroots. Let's make the connection, how we can make the connection. The most consistent, most efficient has been with our local county jail. The vast majority of those interactions happen through email. That's where they get started. It does make me cringe a little bit because I have a different level of confidentiality I have to maintain than does the jail. But we make it through that. And otherwise, it happens through sharing of personal information or contact information and text and calls and things like this to get things moving.
Thank you. Tracy?
One of the things that we've been lucky with is we're co-located. So for our mobile crisis team and our crisis care center, which is our crisis receiving and stabilization service, they're located in the same area. So that helps with warm handoffs. So they're coming back really back to their same office. And so being able to work closely together. Also, we overlapped our shifts so that there's a 30-minute overlap between shifts so that they can do warm handoffs between shifts. And that's been very helpful so that they have some time to do that. Warm handoffs from other teams, just if other teams come in, then they're more than welcome to come back for follow-up and things like that. For example, we had another mobile crisis team bring somebody in who was in crisis. They had follow-up services set up for them the next day, but they needed some safety for about 8 hours. And they were with us in the crisis care center during that time. And they came back the next morning, the mobile crisis did, for their follow-up and transport to the next facility for recovery. And so being able to have those kind of warm handoffs, and we use Teams as well. Plus we have company issued cell phones if we need to keep somebody on the line while our mobile crisis team is coming out, and they need to be able to access people when they're out on the road. They can call back to the center and get information or call out to the client from those cell phones.
Yeah, Megan.
I can't see my chat. It is totally likely operator error on my end, but so I'm just wondering if I'm the only one that is happening to. Because
I can still see it, and I
You
see that
can?
people are typing in it. So
I may leave and come back and see if that works. But I'm wondering, we are looking at, we're having some difficulties with our handing off amongst shifts. And so I am totally interested in what the last person just said about the 30-minute overlap and how you managed to do that. So I'm going to leave and come back, and hopefully I can find that information, but I would love to be able to gather more information about that part.
Hey, Megan, can you see the chat now? I just went ahead and tried to edit something to see if I could add you to it. Are you able to see it now? And I also tagged you.
Oh,
nope.
Thank you for trying, though.
You're welcome.
I know we have quite a few providers on this call that are associated with different parts of the crisis continuum. I am wondering whether it's yourself as a family member, yourself as a client, or maybe being able to share feedback that you've received from a family member or a client themselves about the continuum. I'd really love to hear from that perspective, if comfortable and able.
I have one. Like 2 weeks ago, I had a chance to go talk to some young people that were in a day reporting program, and most of them were already on ankle monitor. And one of the things that the young lady next to me said was, "I wish I knew about this when I was going through my thing. I wouldn't be here today." And so, just getting that word out and making sure that even the young people know about it, because they even see how mental health is being criminalized at times. And I think that's a good angle to kind of get in there, making sure that we are, once we go big in Indiana, just making sure we are reaching out to the young people as well, and the parents.
Derek, I'm curious, is your guys' mobile team connected with the agency, and it could be the same agency even, but are you guys connected with the agency that does Safe Place in your service area counties?
We are, and I've been able to, I have 2 counties, and I've turned both of my mobile teams into mobile safe places.
Okay. Oh.
Well, since it's nice and quiet, I know there's like a lot of people just sitting there thinking. I want to kind of tap back to the handoff, and one of the areas of improvement I found with a handoff externally with us is like the ERs. And what I mean by that is we did all the de-escalating and mediating and getting the kid calm, and then we get there and we tell them what's going on, and you get 3 or 4 people walk in and start putting on their gloves, and what do you think that young person is going to do?
Yeah, the space can be really hard and triggering for folks.
So I can jump in on the 988 perspective of like the handoffs quickly. So I'm Nick Christian. I'm the program director for one of the 988 call centers in the state of Indiana at the Crisis Center in Gary, Indiana. So typically how it will work from a 988 perspective, and just kind of give a general overview, is our crisis specialist will attempt to de-escalate that caller if needed. We do what's called the least invasive intervention, which is approximately 9 steps, 7 of which are going to be like before we even think about a mobile crisis team or a crisis stabilization unit or involuntary dispatch of emergency services. During that time, we will talk about mobile crisis teams. We will talk about crisis stabilization units with the caller. If they do want that, we'll transition that call to actively get them those services. The crisis specialist will stay on the phone with the caller, while our supervisor will reach out to like the mobile crisis team and give them the information about the caller. Our crisis specialist will continue on the phone call with the caller until the mobile crisis team arrives. If it's a crisis stabilization unit, there's a little bit different procedures. We'll collaborate with that caller to see if it's best for them to call the crisis stabilization unit themselves and give them information and kind of prepare for an arrival. Well, we'll also try and stay on the call with the caller until they arrive at the crisis stabilization unit. What else do I have? Yeah, so that's kind of what we do from our perspective. If a caller doesn't necessarily want those immediate services and we're able to de-escalate them, we will create a safety plan with every caller and see if they want those services within their safety plan. So if they're not on a call with 988 in the future, they will have that contact information for their local mobile crisis team or crisis stabilization unit. So really our goal is to de-escalate that caller with our crisis specialist the best we can. We do have a pretty successful rate of that, which probably is leading to the underutilization of mobile crisis teams and crisis stabilization units.
Thanks for sharing, Nick. Yeah, Megan?
Hi, it's me again. I'm wondering, Nick, that just shared about the kind of like 9 kind of procedural things that they're going through before they even dispatch. Is that something that they created, or are they getting that? What is that? How did that come to development?
That's just what we refer to as the least invasive intervention, and it's through a collaboration with 988 Indiana and Vibrant, the national administrator for the 988 Suicide and Crisis Lifeline. Like we said, we want to collaborate with that caller as much as we can, and we don't want to jump to something that may burn that bridge in the future, or it isn't within that collaborative effort. So as long as they collaborate and we're able to de-escalate them and make them safe before we get off that call, we will do that 99 times out of 100 before we dispatch emergency services, dispatch mobile crisis team, or provide details on a crisis stabilization unit. But if needed, we will definitely jump to that if we can't de-escalate them ourselves or they want those services.
And those are really great questions. And so as you all are thinking about these like very specific processes and programs that we run through the state, I'm going to go ahead and drop our org box in the chat. So Megan and everybody in this room, if you all do have any other questions about how does the handoff work or what is like the mechanism for this, we'll be happy to walk those steps through with you. So then that way you all can, have more of that information and more of that insight. So really great questions.
So one theme that we've heard is how the continuum interacts with law enforcement. So I'm curious, just what is everyone's understanding of how the crisis continuum law enforcement interact? And somebody has mentioned what handoffs look like with EMS law enforcement. Again, what's gone well, areas of improvement. I think let's talk about those pieces.
Well, I was waiting for somebody else to go. So we've done a lot of calls with law enforcement. Actually, about 70% of our calls are with law enforcement because they're just still getting those 911 calls. So in 3 of the counties at this point that we serve, after law enforcement is dispatched, then dispatch calls us. It's a mental health call. Officers requesting you guys to come out and make the scene, and so we do. And then we get usually talk to the officer for 5 to 10 minutes. If there's any concern of safety, the officers step out of maybe step out of the home or out of wherever it's at, but stay on the premises just in case. If there is a thought that, hey, this person may need to be transported, but the officer's like, I think they need to be transported, but don't have enough, then we were able to collaborate together to make for that to happen if it needs to. Or there are many times we're able to de-escalate it and do something within the community. So it just we spent a lot of time in CIT trainings with the Memphis model with law enforcement, so they understand how their crisis intervention training through the Memphis model can work together with our crisis, and how those two can come together, and that as we talked about the SIM mapping earlier, that zero intercept model can come together. So being able to be in front of law enforcement like that and talk to them and explain to them, that really, I think that really is a big piece that helps as well.
Thanks for sharing, Chad. Vanessa?
Yeah, I just wanted to add, I think a big part is learning how to walk alongside our law enforcement and first responders. They have filled this gap that we have not filled for decades, and they have put procedures and safeguards in place to meet these needs. So we can't come in and just say, we appreciate it, we've got it from here. because that is not how it can work if we truly want it to be successful and a real integrated model. So it's about being able to have that relationship, and it's different for all of us, even within different, in a single county, you might have different relationships with different law enforcement agencies or first responder agencies. Heck, some of them don't even talk to each other. And so it's about being able to go in and say, how can I walk alongside you? What gaps can I help still to fill? And so I think that to me was just a gap, I think, in how all this got rolled out. All the best of intentions. I think just that missed opportunity to really bring all of us together. And when I'm saying all of us, I mean first responders. So from our, law enforcement, fire, EMS, and then all of us who were planning on doing this to really come together and say, how would this work? How would an emergency detention work? How can this work if I can walk alongside you? What would this look like from dispatch? And I think, again, these are just some unintended consequences of us. Lana, you said it best, I think earlier, the last meeting, which was like, right, we're just building the plane while we're flying it kind of a thing, right? We needed to get these things off the ground and running. And so now I think that's why we have some law enforcement agencies that are like, nope, we're good. I don't care about, crisis services. I really, I don't care about this. It's because they've been meeting this need. We didn't show up for them 30 years ago to be able to help fill this. And so we just have been very intentional with that relationship and being able to honor it at different stages, and trying to figure out how I can make their lives easier. And so, because it takes a lot for them to be able to, because I'm not just having to work with them, but dispatch to be able to change run types or their procedures and those type of things. And there's still, to our point, right, we still have many first responders who aren't familiar with 988 or who don't understand what mobile crisis is. And so I needed to acknowledge kind of this elephant of, we're all trying to do the right thing. It's just about acknowledging some of our counties are more advanced than others, and have a different, greater understanding about all of these things that are happening. And so just trying to figure out, and honestly, maybe not feel alone, that it is difficult. It's not easy. And you're trying to juggle all these relationships and meet all this criteria and all these moving parts, while still trying to maintain that relationship. Because at the end of the day, no matter who writes our paychecks or which area we belong to, it's about how do we help the person that's in need. So I just wanted to bring up that part.
I appreciate that. Kelly? Oh, we can't hear you.
Are you talking to me? Oh no, there's two
No,
Kellys.
Kelly Jensen. Yeah.
Thank you.
You're welcome. We cannot hear you still, Kelly Jensen. My technology advice is always leave and come back. Or feel free to put in the chat if you can't get it to work too. That was about all the IT help I got. I'm curious if there are any law enforcement agencies, officers a part of the call, and I would love to hear your perspective when thinking about crisis continuum rolling out, to Vanessa's point of what do you feel like has gone well and what are opportunities for growth for those of us that are a part of those call lines, mobile teams, crisis centers. Another question that we have is what just overall thoughts of what the plan needs to include from a crisis perspective with this work group really working on the crisis part of the suicide prevention plan for the state. Any things that pop out that would be helpful to include?
I apologize if this sounds simplistic, but in the state suicide prevention plan, probably just an explanation of the different numbers and what they're for and why you might call one versus the other. That might sound super simplistic, but as someone was mentioning earlier in the call, people don't know about 988. So we found that just in our outreach and education, and have just really added it to what, when we're talking about the services that we provide and what services are available. So even just, to the basics for that.
I appreciate that. Sometimes the simple things that we all think about, those are really important things that can get missed. Barbara, are you also thinking about what are warm lines and what are warm lines for, right? Like being able to expand past just one 988 number, but others.
Oh yeah, absolutely. I didn't even think of that, but yeah, absolutely. That's another good one. And just kind of that continuum of, where someone might be where they are. So they may not be in a crisis, and that warm line could be just the thing that they need.
Can you guys hear me now?
Yes. I couldn't find you, but yes.
I went against technology. Awesome. First, let me apologize. I am about an hour late. I am in the middle of a sequential intercept mapping workshop right now, and it's pretty incredible what happens and kind of the happenstance, because one of the things that came up today is veterans and the desire, I'm up in Steuben County, and the desire for either law enforcement or EMS to transport directly to the VA in Fort Wayne. However, there are policies and protocols in place on the state level, I believe, that disallow some EMS and some law enforcement to transport directly to the VA, which sometimes has resulted in veterans in mental health crisis being taken to a hospital further away than the VA. However, they haven't been able to figure out. And so I wanted to bring that to your attention. I apologize again if this is way out in left field in timing. But I wanted to offer that. And then just a little context of where I'm at. I am the Justice Director for NAMI Indiana, and when we had our contract with DMHA, we provide and we continue to provide the technical assistance for the crisis intervention teams, which is CIT. And I know I heard some discussion about CIT as the training. I did want to offer a little clarification that crisis intervention
teams is really more holistic, and it's more engaging than just that 40-hour training. It is about all of the stakeholders that are involved in a mental health crisis, whether that be dispatch, the mental health centers, law enforcement, all of them collaborating on a monthly basis to discuss what that continuum of care looks like as local as possible. So in Indiana, our CIT teams are generally in counties. So I just wanted to make sure that there was a distinction between CIT training and the CIT, which we provide technical assistance for, which is the CIT as in teams.
Thank you, Kelly. And you were not off base at all. We were actually talking about the mapping earlier. So exciting to hear that you were there doing some of that today. Recognizing that we only have 30 minutes left, we really just want to open the floor to any feedback, thoughts, suggestions. Again, we want this to be a space of some opportunities for growth so that we can make sure that those are addressed in the plan, or things that maybe are going really well that one county is doing that is not across the board. So really want to open the floor to any of those pieces.
Just checking in, while folks are thinking, are there any community resources or community agencies that we haven't already talked about today that looping in or adding to our crisis services and our suicide prevention plan could be beneficial? Maybe an untapped resource or someone who's been really helpful.
Adult Protective Services, Adult Protective Services and DCS.
Can you say more, Tracy? Please.
Well, we've had crises where people who were struggling, and potentially the adult was in a situation where they were being exploited, or there was issues where they weren't, where they needed Adult Protective Services to step in for some reason. And we've had a good collaboration with them. We've also had it the other way, where they've been called out and they get there and they said, this is more of a mental health crisis than Adult Protective Services need. Can you guys come out and do an assessment? And it's just been very collaborative.
You bring up a really good point, Tracy. How have you all built that relationship? Adding to what Vanessa had said earlier about the relationship between the first responders and their agency and that critical importance. What about you and DCS and APS?
Probably the same way, just constant contact, right? fact, we had a meeting with DCS this morning. We were just talking about going back out and doing a training on all the services that we offer. Because constant turnover, new people, people forget. If you haven't had to use something for a while, you forget it's there. So I think that ongoing marketing, I think we do a lot of it in the beginning, but just outreach and then just making ourselves available. So giving out our email, our phone numbers, and calling people back and saying, hey, what's going on and how can we help? What's helpful, what's not helpful. Health departments, we've co-responded to situations with the health department before where they said, I think this is more of a mental health. Can you guys come out here? And so just being out in the community, trying to get to community events and get the information out there.
Thanks, Tracy. I know I put you on the spot there. I do appreciate that. Any other resources or agencies that we could tap into that are maybe missing, or we could be standing on their shoulders to help, just push our suicide prevention plan and our programs just that much further?
So we use the power of MOUs, or memorandums of understanding, with our facilities and partnerships, because I think, as we all know on this call, all of our attorneys, and I apologize if there are any attorneys on the call, but they tend to get freaked out when we all communicate. So having MOUs set up with your different organizations that you communicate with will help the attorney's mind, put it at ease. So maybe if we can come up with like a set, like a template, of course, to get people not having to reinvent the wheel, so they don't have to sit at a computer and start from scratch. I might get them to use the MOUs more instead of sitting down. Oh my gosh, I don't know how to do this, and so forth. So if we could come up with one that can be modified to that specific, area, maybe that would help.
Thanks, Lance. That's really good feedback. And I'm also seeing what Nick put in the chat as well, about factual approved resources, and that ability to provide in-depth education. And so it sounds like resource sharing is something that's critically important, that may be missing, not only in terms of MOUs, but education just in general. Are there any other pieces of policy, of any documentation, any other types of resources where, instead of recreating the wheel, that maybe we have that we could share with one another, or we're missing that we vitally need? Kat, I'll get to you in just a second. Yeah, go ahead, Chad.
So I think one of the resources that I found has been helpful is we've been able to have some meetings with church leaders. What I found out was a lot of these pastors have meetings amongst themselves, sort of being those meetings that they have maybe every quarter, where they bring a bunch of the law enforcement together, or a bunch of the pastors together. I've been able to present to a few of those, and there's been some calls come from those, where, one of the calls was, there was a lady from California that was brought here by her boyfriend, and he beat her up and he threw her out in a rural area, and the church was the one that ended up picking her up and taking her and getting some food, and then they called us for to come help, and we were able to find a pathway for her to get back home. So having that relationship as well, and we've also used them the other way where we've needed, Catholic charities or something to help out. So having that relationship is really important.
That's really helpful. So we've talked a lot about first responders. I've heard you just mention faith leaders and in different congregations. I saw somebody mention in the chat a bit ago about using like doctor's offices and schools and that kind of thing. But Chad, you brought up a really interesting point that just kind of tickled my brain. We do have a vast majority of our counties in the state. I think it's 57 of the 92 counties are identified as rural in the state of Indiana. And so how are we responding in those spaces, or what are the gaps for folks that maybe are out in rural spaces or maybe don't have as many accesses to local resources? Any feedback there from anyone?
I've noticed that the rural communities that we're serving are doing a lot of the CIT trainings, which I think has been really helpful to get rural community law enforcement up to speed on mental health, and then collaborating with them for joint mobile responses has been very effective for us in those rural communities. They can often show up quicker than our mobile team who may be in a neighbor, a hub county, and these are the neighboring folks. But if you can get the trained law enforcement there quickly, and then we can show up and take over.
And how about buy-in when it comes to folks maybe in more rural communities or communities where maybe there's not as many resources? How will have you engaged the community there? Or what are the gaps there for that engagement?
Well, sometimes we work with local community foundations and try and get some of those resources there. We look at other agencies that provide information or resources. Sometimes we create our own resources. So, for example, we have a food pantry in our Switzerland County office. We don't have that anywhere else, but we work with Greater Cincinnati Food Pantry, and we offer a food pantry out in Switzerland County. So, I mean, I think sometimes you just get creative in what you can offer. And in the world of telehealth, sometimes you can get resources that way as well. So if we can get people to our local office, maybe they can telehealth into some resources as well.
For anybody on the call, are there any communities throughout the state or any like counties throughout the state where really getting that buy-in, from certain leaders has been crucial, or maybe that's an area where we're needing to tap in further? As you all are thinking, where my brain goes to is I know that Purdue Connect has a program. It's the Farm Stress Program where they connect with farmers to give them resources, mental health resources and support. So just an example of that. Yeah, Vanessa.
So definitely not rural, but I'd say even for our counties, communities like Marion County, while it's definitely not rural by any means, it is so complex. There are so many moving parts. There are so many entities beyond the community mental health centers or different types of mobile crisis response. There's just so many players that it at times feels overwhelming and daunting to just be like, I guess we're just going to have 20 of us all doing the exact same thing because we can't figure out that way to make it work. And so I just wanted to acknowledge on the flip side, you can have so many, almost too many resources that it makes it just as complicated to get all the players to the table and figure out where does the energy and the focus need to be.
Yeah, great feedback. Thanks for that, Vanessa. Anybody else? Any other feedback on that?
This is Megan.
I feel like we've noticed. Oh, sorry, Megan, go ahead.
Oh, okay, I'll be quick, but I just know that for our current circumstances, we have 4 counties that we serve in Southern Indiana, and so 2 of those we're doing pretty well with, 2 not so much, and so we have had some instances where I think that it just relationship building that we've got to work on and them understanding kind of what our role is. They called us and asked us for help, and we weren't very helpful because I think there was some misconceived perceptions about what we can do and what we can't do kind of thing. And so that's something that I'm working on now, is just trying to like repair some of that has happened and then like trying to get buy-in to move forward. And so being realistic about what we can do. I mean, we don't have like bulletproof vest like to show up and navigate those kind of things. And so yeah, that's been a bit of a challenge. It's going great, and I think sometimes that in two of our counties, and I think that has kind of complicated it too, because they're like, "What about us?" kind of thing. So that's part of what we're working on, is to try to just like kind of just what everybody's already talking about, just that collaboration and building relationships and building back trust and educating them on what we can and can't do. So we've got some work to do.
And so in terms of the state suicide prevention plan, I've heard a lot of really great feedback and suggestions from folks. Is there anything that we could take back and maybe tangibly add to that plan in terms of that relationship building, the marketing pieces, anything else that we could take as a tangible to support that?
Can you ask that question again?
Yeah. So in terms of relationship building, getting education out, those kinds of things, is there anything that we can do as we're considering implementing the state plan for suicide prevention that we could maybe take steps towards? Because relationship building is a very, very broad topic. Buy-in is a very, very broad topic. Is there anything that we can do to maybe conceptualize and operationalize it into something tangible?
I think pointing out the things that are already there in the counties. So Kelly Benedict earlier talked about why CIT teams can be so successful because of the collaboration that they have. And as Kelly Jensen was pointing out, it's not just a training, it's because they have this continuous meeting of the resources that's ongoing, where they answer those questions and they figure out what to do for things like transportation. That's actually an issue that has to be addressed almost every single time a new CIT team is put together in different counties. But there's also like the JRACs, and there's other groups that are already meeting and already working to that end. And so pointing out those and who maybe the contact is, or at least at the state level, who the contact is, so that people don't have to reinvent this every single time they want to do some collaboration or if there's turnover.
That's great feedback. And Barbara, can you add in the chat any folks, because you listed a number of different things from justice involvement to folks at the state, anybody that maybe you would see being very helpful in putting those pieces together and continuing that collaboration would be great. And Megan, yeah.
Just wondering if it would be helpful to have maybe like a specific spot where we could go to access like stats on saving money and why this works and why it's important. Like, I don't know. I mean, there's some of that already out there, but if there's like a more central location that we could utilize, just to like outline in the benefits and why it's, why it's working in other areas, across the country, and to help with that buy-in, because obviously a lot of this comes down to saving money and saving time too, right? For our community partners and what value we can bring to the table kind of thing. So maybe like a centralized location for those things.
That's excellent. Thank you. Derek, I see you're next.
Thank you. I agree with I agree with Barbara and Megan said, but I'm not quite sure how to ask my question or put my statement out there, so I'm just going to kind of throw it off the top of my head a little bit. In the perfect world, what does the best practices look like for treatment around suicide, and getting a good idea of what that looks like, and being able to make sure that we have those in our community, if that makes sense?
Yeah, it does. And so you're talking about not necessarily even just like the tool, whatever that evidence-based intervention is or the theory behind that, but the person that's in front of you, right? How are we making that applicable to the person or people that we're serving? Did I understand that correctly, Derek?
I agree. Yes, ma'am.
Okay. Yeah, no, that's helpful. Anything else that you'd want to add to that? Because that's a whole big can of worms that is really important. We haven't even touched on today.
I mean, just to put some context to it, as I started building this out and the smoke started to clear a little bit, I started looking at who are our supports for suicide when it comes to someone in crisis. And as I really did some research, we are it. And I'm not really comfortable with that, if that makes sense. And I would like to know, what does a community look like in a perfect world? Best practices, what does that community look like for those struggling with suicide ideation and suicide attempts and things like that?
Yeah.
And then add one more thing to that. A lot of the medicine, well, I'm not gonna say a lot of the medicine, a good amount of the medicine that our young people and even adults use, that triggers suicide ideation, and they are not creating anything to support that, and that's troubling.
So considering things outside of the medical model,
Mhm.
a lifespan approach, a holistic approach, and then also education when it does come to psychotropics, or
Mhm.
when the medical model does need to take over in a long-term perspective. Is that right, Derek?
And you so smart, you got it.
Derek, I always love chatting with you. You always bring me joy. Thank you for that feedback. And then yeah, Tracy. Hey, Tracy, I don't know if you still had something you wanted to share on. I saw your hand
Oh,
was up.
sorry. I
You're
thought I
good.
hit unmute.
You're good.
So maybe some training around the ED process and emergency detention process and what that looks like. So cross training so that law enforcement's hearing the same things as we're hearing, and everybody's getting a good understanding of how that all interacts together with the judges and transportation and how that all works. Because I do think there's still a lot of confusions with the law changes with the hospital system and everybody involved in the whole continuum. And we're having local meetings on that, but just as kind of a whole state overarching approach. And then kind of one of the things that has helped us here that I think might be helpful in a plan is looking at, when do you use an emergency number when you call in? So if our crisis line or our mobile crisis team has something going on, when would they use the emergency number to get law enforcement involved versus when you would use kind of just calling your local dispatch number and not going through the emergency route? That's been one of the things that we figured out in our interaction procedure, that if we were starting up in the beginning, kind of those MOUs, like how do you want to use this? What's the best way to interact? When do we call the emergency line versus just calling dispatch, so that we're not, involving and tying up the emergency line?
Yeah, and so what I've heard throughout today is so education, very simplistic isn't the word I want to use, but like simplistic socialization for providers, law enforcement, community members, the person in crisis, loved ones whose loved one is experiencing a crisis, education, like DOE, interagency, that kind of thing. So it sounds like different levels of education, different levels of addressing stigma, the processes and procedures, that kind of thing. It sounds like what I'm hearing. So yeah, Chad.
Yeah, one thing I wanted to put in there is, I saw in the chat about CIT trainings and gravely disabled. As working with a lot of officers that have been CIT trained and everything like that, they still really don't understand gravely disabled and are very hesitant to do that 48-hour transport hold to a facility if need be. So I think some education on what gravely disabled looks like and what they can do with that, because they can see that this person needs to go someplace, but if all they have is gravely disabled, many times you cannot get what you need. And you have to wait till they've became, maybe quit drinking, quit doing something, to where now the ambulance can do something, but that's 2 weeks down the road when they could have been handled and been back in real life much quicker.
Thanks, Chad. And so it sounds like there's a need for bidirectional feedback between first responders, the provider, or the person, there's really this need for bidirectional feedback of what resources are available, where do we kind of take over, where do you all take over, and then how can we collaborate? That sounds like is needed. Yeah, Vanessa.
Yeah, I was just responding back to Chad. I guess I totally understand where you're coming from. My stance is that's not their subject matter expertise. Just like you don't want me probably arresting you because I couldn't tell you what any of the laws or rules are. Like we put them in a situation to make a determination about mental health, and they don't have, I mean, I would love it if my background and training was only 40 hours and I got to get my master's and fully licensed, right? Like that's just not the reality, which is why other states have deputized licensed providers to be able to make that qualification. So it isn't just lying in the law enforcement hands. So it would be something, and there's examples of this across many states that I would ask Indiana to take a look at to see, is that something we can do so that we don't have this back and forth or creating this, see, they're the problem. They're the reason why we can't get, Johnny help or whatever, because they don't realize that this is gravely disabled, instead of it just creating like, let's take that burden off, or make this a team approach so that it isn't just the officer making that decision. It can be somebody with subject matter expertise walking alongside them. So I just would ask if that is something potentially the state could look at, is how do we alleviate that confusion? To me, it's not about simply training officers. It's about how do we help them?
Gotcha. Thanks so much for that feedback, Vanessa. Alrighty, and so we've got about 7 minutes left, so we want to make sure that we're providing space for any last minute comments or questions. But for Alana, Laura, or Elizabeth, anything else that you folks want to make sure we address, or anything that you thought of from our work group perspective that we want to get added? Okay, I see Alana say no.
I'm okay. I just appreciate everyone being so active in the conversation and bringing so much to the table. It's a lot for us to consider and a lot for us to mull over while we're implementing all of this information that you've provided for us. So thank you.
I don't have any additional questions. It's been interesting to watch. Taking notes for the last 2 hours is a lot of information. So it's been interesting to process the information as I'm typing it, like, oh, this is the theme I'm seeing. This is the theme I'm seeing. So I thank you all for your time. I know 2 hours in the middle of the day is a lot to ask people in crisis world, especially, to come offline and be available and give us your brain and your energy. So thank you very much.
Alrighty, so I'm going to go ahead and share my screen just so that way, like Laura and everybody just shared, this is a lot of information to go through in a couple of hours, and there might be some things that you on your drive home today, you're thinking, "Ooh, I wish I would have brought that up," or what Derek said, or what Laura had said really made me think. So if you have anything else that you'd like to share or would like to add additional context to, if you could email Laura and myself We'll be compiling all of the information, and then our awesome work group is really going to contextualize it and come up with the plan, and we'll move forward with that. So please go ahead and take this down, our email addresses. We will be sending out the recording to everybody, but please don't hesitate to reach out if you all need anything further. We really do appreciate your time. All right, thanks so much, everybody. Bye.